notes.
We'll see how we go. We're due to finish at 5. We don't have to draw it out if we run out of things to say, but with Professor Kuter here, we very rarely run out of things to say. Yeah, he can't respond to that.
I can always respond to that, Adrian.
And you'll notice that fatigue and depression have come up on several presentations. I have nothing specific on that this time. I'm aiming for a presentation of that when we have our next convention, which will be in Manchester around this time next year. So, but we can discuss that because there's considerable interest, and we see through the association, we still get quite a few questions of people coming up to discuss issues of fatigue. David has just published something, or has something just about to be published on a survey that they've done in the States on that. Would you like to just summarize that, David, if you remember what you said?
This is a hard audience to be part of, I'll tell you that. So I think you're talking about our cognitive function study.
Yes.
Yeah. So we and Dr. Cooper and others have looked at cognitive dysfunction IT patients, found that a significant proportion of patients, well over 50%, have what's known as cognitive dysfunction, measured by different tests we can apply to patients. And we found that patients with ITP have a mild cognitive dysfunction that's present at the diagnosis in patients who went on a study of ours. Please note that the patient went on our study of ours had ITP over 8 years, have been treated with more than 4 other therapies. But in that assessment, we found that the cognitive dysfunction was comparable to patients who had a small stroke. Why this is happening, I can't say. It's not something we yet know whether it'll improve with therapy. I think that the other aspect of this discussion that Adrian is bringing up is, are there any therapies that make fatigue better? And so far, there's only one publication of which I'm aware that suggests that if you get your platelet count into good range, your fatigue score improves. With a thing called a complement inhibitor, we showed that in ITP patients, fatigue scores got better in a wide range of diseases. So I think there are therapies that are evolving that might be more effective in correcting fatigue than some of the current therapies we have, but we're not quite yet at the state we recommend that.
But there's certainly a big question that comes up time and again on our, particularly on the ITP Facebook site, is my platelet count has reached this level, but I still feel fatigued. I think there's little association between platelet levels and.
Yeah, and I think that's unfortunately, as I said the other day to our group, the adult group, 80% of patients going to primary care docs complain of fatigue. That was my main complaint when I see my doctor, and I'm not to be dismissive, but I think right now it's important to recognize fatigue may be part of your if you have ITP, fatigue may be part of your disease, but almost may be due to the 12 other things going on in your life that could cause you to be fatigued. So it's not the only cause of fatigue. But I think right now it's a cause which we shouldn't ignore, and it may be due to ITP, and it may be that some therapies that we develop or going forward will make it better.
There's also, I think, from the Scandinavian registries, they published some great data from there, and they've again had something recently with increased use of antidepressants and other anxiolytics in patients with ITP. And I wonder how much of that's genuine, how much people get treated when it's not really necessary. And I wonder, I'll throw that to the audience as well as the panel to see if they have any thoughts about that.
Well, Adrian, as I mentioned, we've done the Optimum database study of 186 million American insured lives and looked at ITP patients we could glean out of the database. And what was interesting is the use of antidepressant drugs was 4-fold higher than in the control population, adjusted for age, gender, geographic location. So I think that we tend to use a lot more antidepressants in autoimmune disease than we do in other patients.
Yeah. Any questions from the audience? The one that, yes, one in the middle here.
Yeah. Oh yeah. Yeah, it's along the lines of what you've been talking about. So I've read a few research articles about depression and platelets, and just to quote a few, platelets contain high amounts of serotonin, and a dysfunction of the serotonergic system is involved in the development of several behavior disorders such as depression, etc., etc. Another one states that platelets store 99% of the body's serotonin. given the established link between serotonin and depression, and the fact that the platelets contain 99% of the body's serotonin, etc., etc. Another one, I won't read them all, but researchers identify a biomarker in platelets that tracks the extent of depression. Yeah, another one, the relationship between platelets, serotonin transporters, and depression and fatigue.
Did you put the question on Facebook?
I did, yeah.
Okay.
And
My understanding
A couple of us have
is,
spoken about it today, so I think it's quite.
my understanding is, I'm sure others have a thought, serotonin doesn't cross the blood-brain barrier.
Yeah, that's the problem. And I think, it's
So,
not-
yes.
and it's not 99%. Platelets contain about 10%. Most of the serotonin's in our brain, and it gets produced by these things called enterochromaffin cells in our gut. But platelets pick up about 10% of it. And it was thought that might be a possibility of why there's mood disorders and things like that. But as Adrian said, it doesn't cross the blood-brain barrier. So I don't know if that's really the reason. But you know, that could be. It's possible that it might have a relationship.
Okay, so something that's not really known yet. You
No.
would sort of disagree with a lot of those articles,
I
or
don't disagree with them. It's just that,
And I-
well, 99% of the serotonin, that
It contain, the platelets contain 99% of the blood's serotonin.
serotonin, yes, that's probably what it means.
That's what that publication that we
Yeah.
put out states.
Yeah.
It's not the total body serotonin.
No.
We
Okay,
published
thank
that
you.
years ago.
Okay, thank you.
Until she had her very low platelet count. And she felt straight afterwards that there had been some kind of chemical change in the way in which she experienced any joy in life. After having a severely depleted platelet count, which came on very quick. So I do question as to whether there is something going on there. I don't believe it was all circumstantial. I think there must be something chemical going on.
Well, there's certainly an association, and I think this is one of the, where it came to the fore a few years ago, that patients would come in and say, my platelet count's fallen. I think my platelet count's fallen because I suddenly feel fatigued, or rather than depressed, but fatigued. And the platelet count would have fallen. Now, the corollary doesn't mean to say that if the platelet count goes up, you feel better. But there's clearly an association between the low platelet count, but it's not a 100% association. So there's a lot of work needs to be done to tease out what the association is and what the chemicals are. You know, something like tryptophan, which is a precursor of serotonin, does cross the blood-brain barrier. Now, is it related to that? Should you treat tryptophan? A few years ago had a vogue for treatment of depression. It wasn't particularly effective. Yeah.
And she has continued to experience fatigue.
Yeah.
But we don't think that fatigue is related to the other blood problems she's got.
Yeah.
But she doesn't feel as low as she did.
Okay, Drew.
Yeah, I just I think fixating on serotonin is probably a slight mistake. I think it's an inflammatory response, and in many autoimmune diseases, when the disease is very active, there are lots of inflammatory molecules around, and that does make people feel tired with rheumatoid disease or primary biliary cirrhosis and ITP. So I think it's part of the disease activity. And then we also know from the patient survey, that anxiety and fear about platelets crashing and will I be stable, and or maybe I won't be stable. It sets up a whole cycle of worry about your platelet count and the future. I think that also as an overlay on top of the inflammatory response is a whole additive thing. I think serotonin by itself is far too simplistic to be the answer, and I wouldn't want to go down that rabbit hole too long.
The honest answer is we don't know what causes it, and we don't know how to make it better. I will make one further comment that others know here, which is that in other autoimmune diseases, other diseases of blood destruction, red cell destruction, paroxysmal nocturnal hemoglobinuria, and a thing called warm autoimmune hemolysis, where antibodies knock your cold antibody hemolysis, where you knock your red cells down. We've shown that drugs that make those diseases get better oftentimes don't change the hemoglobin, but you feel terrific on the drug because it inhibits a substance called complement, which is a major portion of your inflammatory system. So there's a lot of stuff going on here, and that may apply to ITP. It may not apply to ITP.
No, I was just going to add, I think the other important thing though, is to recognize that while there is an association and we recognize that association it's also very important to look for other causes of fatigue in patients with ITP, to never be overlooking that there might be something else going on. Truly discussing other factors that might be impacting mental health, that might be impacting energy levels, such as iron studies, if somebody's having significant bleeding, thyroid studies. So I think the other thing is not to get too, oh, it's always the ITP and the fatigue is related to the ITP, and making sure that we're really looking for other causes of fatigue in patients as well. Yeah, yeah. So just,
It's important to check thyroid function in these patients. There's a high increased risk of Hashimoto's thyroiditis in patients with ITP.
And vitamin D.
Yeah.
I just wanted to ask a bit more about this research on cognitive dysfunction. I mean, can you say a bit more about how many people were involved in this study?
This is a study of 60 patients, about 49 per the FDA requirements for a study were asked to do a cognitive function test.
Yeah.
And it's something that all politicians probably ought to have done, but that's a different story. I will simply say that in the 49 patients that we studied, these are all the patients who were in the study I ran, they had significant dysfunction. But significant, it does not mean it was horrible. It doesn't mean that they were stroked out of or had Alzheimer's, but they had discernible differences compared to normal by at least 1 log difference.
Are we talking about problem solving or brain fog?
It was problem solving, visual acuity, problem solving, that the fog that many people, maybe some of you have complained about. These are things that are not readily identifiable by blood tests, but I used to be very not very happy about these cognitive function tests because I think they're very good. But when you got a database that's enormous for healthy volunteers and other diseases, these are actually reasonably robust studies, albeit not as precise as a target on a wall, but they do give you data that says there is a cognitive dysfunction. These patients had ITP for on average 8 years. They had received at least 4 prior therapies, and they were the losers, the folks who didn't respond to much anything. I won't use the word refractory because I don't like that word, but these are patients who were late in their course of disease, if I may use that term.
Right. So we're just talking about refractory. Whatever.
Don't use that word. That's not allowed anymore. Okay. Sorry. Next year.
I'll put it in we're going to put it in the trash, not the recycling.
Patients who are not in remission. How's that for a statement? Okay.
But in terms of causes and relationships.
Again, we are, as Dr. Cooper has shown, some patients with ITP have what are called microbleeds that can be detected on a scan, but those didn't correlate with cognitive dysfunction. I need for lab here. I don't want to speak for a lab, but those patients who had the microbleeds did not have a correlative with the cognitive dysfunction.
And could there be a relationship with the number of treatments that patient?
So we could spend an hour talking about this, and if you read our paper, there's a long discussion there, and it says it could be a thrombotic problem, it could be a bleeding problem, it could be an inflammatory problem. This is going to give us a lot of work. We have a whole team right now working on this.
Sounds interesting. Okay.
The other question I would have, Dave, is could any of the cognitive challenges be related to depression and anxiety? Because I think it was interesting, the trapeze study that Adrian and Mervyn started from here looking at, and it was driven by a patient focus rather than the IWISH, which was badged to the physician surveys. We didn't ask about employment in the UK, but in the Italy and Netherlands, there was also a significant difference in levels of employment and function, and people felt they had to take a step back. So I think it would be nice to get funding to be able to start to investigate some of these things.
I'd also be very cautious about taking home message from this statement that cognitive dysfunction is not, because I don't want an IT patient to say to his or her spouse, I'm the way I am because of this. We don't know that to be true yet. I think it's just a single point in time. We don't know whether it's going to progress or whether it's there all along, or there's other things that cause it. We also don't know if treatment makes a difference, but it's something that's being looked at right now.
Yeah, which comes first?
Fred, did you?
Yeah, I was just wondering, do you think we have enough data from IWISH and other questionnaires to design some sort of standardized questionnaire to capture ITP symptoms, including fatigue and cognitive impairment? That could be quite useful, I think.
Well, there's a company called Cogstate that sold us this cognitive function that has a huge database to it. And it's also an NIH cognitive function test you can get for free to do in clinical studies. wish I could bring the iPad and show how this thing works, because I think half of us would fail the course, but I'm not
I mean,
gonna
in
go there.
other areas of hematology, for example, in myeloproliferative disease, they have a kind of a standard, a very simple standardized symptom assessment questionnaire called MPN-10. And that can be correlated with disease status, with the genotype and so forth. Maybe something like that would be quite useful for ITP.
Drew, any comments on, I mean, you've done clinical trials in ITP for years. They do use some quality of life scores. Drew?
Sorry.
Oh.
He's busy selling one of his artworks online. Fred
that
had,
word in
yeah. Yeah. Fred had asked about quality of life scores, and in your experience with trials, particularly having run the trial, set up the trial for oral trauma pag originally, the quality of life scores in ITP and how they, are they good? Should we do better? Can we do better? Fred was talking about the MPN one, but there are some scores, aren't there, for
There are-
quality of life?
Problems, there are so many different tools for quality of life, and I mean, they're all much of a muchness. I mean, they're worth doing. I think I try and keep it as simple as possible, because people are stressed enough and have enough forms to fill in, electronic forms. So I think keep it fairly brief rather than one extensive questionnaire, and then it give us some information, I guess. I mean, it's not difficult to set up. It's just another task for the investigators to complete.
Trouble is, the trials are often quite small, and you have a selective tool to measure it, and you're often looking at confirmation bias. I think you're proving what you think you're going to find with some of these studies.
And as Dave said, often the trials have quite refractory patients.
Yes.
I'm not allowed to. I'm sorry. Patients who've had multiple lines of treatment, and you can't assume that that's
Yeah.
the same.
Say patients.
Which, going back to the word that we can't be using anymore. Yeah, we need a scoring scheme for disease severity, that you get points for different things like duration, prior therapies, and there is a group working on this right now, maybe several groups.
Have one.
Yeah, and I think, because I think what happens, right, is we have a measure for fatigue, a measure for cognitive, a measure for bleeding, a measure for quality of life. And there's nothing that really comprehensively puts it together. And it's, in a research setting, it's fine to ask a patient to fill out 15 different forms and, really get to granular data. But in the office, I think what we're really trying to do is just get clinicians to have it on their radar to be thinking about these things and asking these questions. And the simpler we can make that to at least begin that conversation is probably a stepping stone, and better than where we are now, where I think some patients never get asked these questions during a visit.
And I have a
Right?
question for you guys. How many minutes does your doctor give you in your conversation with him? How much time do you have with the doctor to discuss your disease? How many minutes? 10 minutes. Anyone get higher than 10 minutes?
I mean, I think part of the issue is, and I think this came up under Nikki's presentation, you often get a lot more information out and a lot of information back when the patient talks in the out of clinic setting to often the clinical nurse specialist, because they're more relaxed, they have more time, they don't feel pressured, they don't feel there's a whole queue of people outside wanting to come in, and they've been late in anyway, so they tend to forget. And I think that's part of the shared care thing. What questions you want to ask, make sure you've got them there. So, Steve.
It's a great lead in for what I wanted to ask, actually, which is basically I work in a South London centre and have recently managed after many years to get an ITP nurse specialist. And so there's not many of those around. They're fairly rare. And it's coming around to the time when the funding is going to say, well, that's done now. And we've had a local audit and asked patients what they think of the service, and everyone, 97% have said it's phenomenal. It's just changed completely. And I mean, it is interesting, and certainly from when we talk more and more about shared care decision-making, it's impossible in the clinic for the consultant and the patient to run through the various stages involved in a proper shared care decision making about management or diagnosis tests or anything really. And so I've seen this big change, but I was just interested and wanted to put it to the floor or the panel really about the nurse specialists, because I wanted to find out your own experiences from your centres what you do if you need to try and contact someone, because from my experience, the nurse specialist has transformed our service, and I'd like to think that it was more readily available and nationally. But if anyone's got any comments about that, I'd appreciate that, because I'll be taking that back with me to help fight to keep the nurse specialist role.
I think that there's been a feeling through the clinical forum that the number of clinical nurse specialists in ITP has dropped off a bit recently, and that reflects funding and is something to be resisted. And I know that Louise Taylor, who I think has gone now, has worked very hard to try and increase the level of interest in the education of those groups. But I think you should fight it. I think they're a pivotal person within the unit for both contact and for information giving and for information receiving.
You've got to know her careful, she's committed, know her history better than anyone else. And when she actually a couple of times they stepped in and insisted I would go and have treatment or have tests and spoken to the consultant. And I thank them so much.
Yes, I think that's a good point to finish this discussion on that on. And let's move on. Are there any further questions? Or I think I can see a hand waving in the gloom.
The vitamin D levels and iron levels have been mentioned a couple of times, and I'm interested in numbers. And I want to know that if you have an autoimmune disease, should the vitamin D and iron levels be higher than the healthy patients? And the other question is that if the iron level is very high, would you be worried when it's ITP patient?
Well, we tend to measure these things in all of our patients as general doctors. And so Boston doesn't much sunlight. And so everyone's vitamin D deficient in Boston. So we give them all, everyone gets vitamin D. If your iron level is high, I'd worry about you having hemochromatosis, which is another disease that oftentimes gets misdiagnosed. But again, it's not something that I think one has to treat most patients with unless you're bleeding, a woman menstruating heavily, or have some other disorder of iron loss. So I don't see a need to give people iron unless you document iron deficiency. But a higher iron level to me does not ask for health.
In our centre in the East End, one of the commonest tests requested is the vitamin D level. Now, if anyone knows the demographics of the East End, you'll know that 98% of those patients are vitamin D deficient because they're covered up and there's no sunshine. So we were trying to persuade the GPs, just give vitamin D, you don't need to do the test. But I think a lot of people started taking vitamin D during COVID because of the suggestion that vitamin D may help you recover more quickly. And I think there has been a surge of vitamin D supplementation over that, which many people have kept on. And we do try and encourage people to take vitamin D in the UK through the winter months anyway, just because of the lack of sunlight. But I agree with the points that David's made about iron. It should be checked. I think Nikki made the point as well. Certain teenagers do become iron deficient. Girls because of their menorrhagia as their periods start, and boys because of the growth spurt. So that's something you have to be alert to in that adolescent population. But otherwise, it's you can look at the blood and have a decision as to whether you think you ought to follow the iron levels. Of course, you won't be able to pick up raised iron levels. That's something that's often only picked up in most practices too late for patients who've got hemochromatosis, which is one of the most common inherited disorders in the Caucasian populations.
And with regards to iron testing, there's two different tests for iron. There's an iron level and then a ferritin, and one is just sort of your baseline iron, and the other is your storage of iron, which is the ferritin. Your iron may go up if you eat something high in iron before the visit, that's going to bump that level up. It's very sensitive to what you just had prior to checking. The ferritin is what we call an acute phase. So if you're even, sick, you have a little cold, it can also bump up a little bit and then it will come back down. So not putting a lot of stock in just a one time, the hemochromatosis, it's going to be over time, very high levels and build up, not just these kind of bumps. So the tests themselves are very responsive to acute things. So I wouldn't necessarily be too concerned if it's one value slightly above normal.
And the ferritin oftentimes, as Cindy was saying, more inflammation than iron status in some disease states.
Yeah. Okay. Let's.
I found Dr. Chen's research on the efficacy of a splenectomy very interesting. And I'm curious to the panel. So in the study, it showed that a splenectomy as a first-line treatment was effective. And then now, post-splenectomy, that the treatments are not as effective. So seeing this study and as new treatments are coming out, do you think that a splenectomy would ever be reintroduced to the guidelines? Because as of now, it's being taken as a last resort.
That's interesting. I was going to talk about splenectomy next, so thanks for bringing it up. I'm just going to make one provocative statement that came out of Fred's statement. It's something I've always felt strongly about. A lot of the splenectomy data comes from times when it was used very much as second line, and I would postulate that the majority of those patients didn't need a splenectomy. And the majority of patients who now have a splenectomy as a last resort treatment, it's totally ineffectual. And the only person that's treating is the physician who suggests they should have it done. So I think taking a spleen out of a patient is doing them a disservice and should only be done with carefully monitored, particularly at the moment, indium labeled platelet survival, which isn't perfect, but it's better than nothing. I know David here feels that if he had ITP, he'd have his spleen out and forget about it all. And I think there's a strong argument to support that. So I'd be interested on the panel's thoughts about splenectomy.
If I had ITP, I think at some stage I get frustrated with having to be seeing doctors all the time and taking pills. I might, as give my own persona, have my spleen taken out. But I don't recommend it anyway because we have many options. I just don't like taking pills.
Yeah,
but that's my psychoanalysis of myself.
I'd have an indium label platelet study, and if it was splenic sequestration, I'd have my spleen out and forget about it. Except you'd then have to take penicillin for the rest of your life. But I think
have a double thrombosis risk. Okay,
so I think the concept that you say to the patient, well, we'll try all these things. If they don't work, we'll take your spleen out. I can predict it won't work. I know it won't work. And we see cases discussed in the Facebook page and on the ITP clinical forum page. Oh, we're now going to take the spleen out. And I just want to write and say in capital letters, do not do that. The registry data shows it does not work. Don't do it.
Patients.
Sorry, there's a question there. Do you want to talk to the microphone?
You also check with a liver spleen scan?
Yes.
For splenectomy?
No. Well, the indium label scan shows that because it shows where the platelets go and where they're destroyed. So the scan shows that picture.
It's common procedure before splenectomy.
Yeah, yes.
Okay, no, that's good.
I mean, we rarely do it now because we don't take spleens out, and that's based on the data that we did through the registry that we presented. And Fred's now trying to drill back into some of that historical data that we published to see if patients in whom splenectomy worked still maintain a response. And we're trying to, if you ever worked with the nuclear medicine department, you know they're a nightmare. But he's trying to work with them to persuade them to get some of that data that we can reanalyze.
Are you still doing spleen scans in the UK?
Very rarely, but
who does them?
We still have the
okay. We
have the technology available. It's true. Did you?
Yeah, I just think taking someone's spleen out in this day and age is so archaic. I mean, the spleen is not a redundant organ. You know, this is a huge chunk of your immune system which is taken out in one fell swoop. So I would say nobody should ever have a splenectomy unless they beg you to have one, and then then you could do it. And I understand that you have it done and then your platelets are good and you don't have to take medicine, but you have still removed a large section of your immune system.
You're creating one disease to create.
Exactly. Then you're at lifelong risk of overwhelming infection with certain bacteria, but also.
And you saw from Walid's data, you have significantly increased risk of thrombosis as well.
Exactly. So, I mean, it's like decapitation for a headache. It's not the answer. It's not the answer. Maybe in the 1950s and 60s it was, but nowadays really nobody should be facing splenectomy. And I think some treatments work better when your spleen is removed as well, though. It can sometimes change the response to somebody you might not have responded to before when the spleen is gone. But we never splenectomize anyone.
Okay, but before Carolyn asks a question, I'll just make one other point. We're going to ask Well, to re-record his talk so he can put it on the website so he won't sound like a Dalek. Caroline,
So sticking with splenectomy, I remember when I had my spleen out, the next day my platelets were 150, and then a week later they were 7, and the surgeon said to me, "Well, I consider that a partial success." So, I'm wondering how long patients are really followed, that have had splenectomy. And then my other question is, I ended up going into remission about a year later, and I did have an unnamed medical advisor say to me, "Well, we do give it up to a year to consider it splenectomy being successful." And I'm just wondering how the panelists feel about that.
that's a little bit like the discussion of rituximab responses initially, where you had triple responses, those who responded initially, those who responded after a little bit, and those who responded 6 months later. And they still said the 6 months later one was a response to rituximab, which seemed to me just a good way of publishing a paper, but not real data. Comments about splenectomy further? No.
Yeah, well, I think not that I ever do splenectomy, but it usually works a bit faster than a year. It's unusual for it to be a year. I don't think that was something else that changed rather than the splenectomy, I would suspect.
Yeah.
Do you think it's some sort of remission?
Caroline, I think that late response is probably an act of God or something. I'm not here to joke about this, but I do think right now that most people respond rather rapidly, but many people respond as you did for a couple of days, and it crashes again. Yes, I think we got to recognize that it's not but again, this was the main therapy for ITP for 75 years. So I mean, we shouldn't be totally dismissive of it not working. It's just that we have so many options right now, as Drew was saying, that it's not something we have to offer. I've only done 2 splenectomies in the last 35 years on patients. They're both Air Force pilots who need to get back in the air and said, "I want the spleen out tomorrow because I want to fly."
But that was a lack of alternate therapies. And the majority of those patients who had that as almost, it was even used as in the 50s as often first-line therapy. Yeah. Many of those didn't need surgery.
I agree completely.
Yeah, yeah.
So as patients and patient organizations and clinicians, how can we do a better job of helping convince other clinicians that that's not something that should be done?
Insist upon a second opinion.
Yes.
At an ITP center.
Because a lot of teaching of ITP, and the majority of doctors who won't do hematology will get 5 minutes of a lecture, and they'll know if they need treatment, and often they feel they'll always need treatment. ITP, you give them steroids, they don't respond, you take the spleen out. And that's sort of wedded into the conscious level of a lot of people who aren't specialists. It's one of the reasons why we tried to set up the specialist centres around the UK to stop that sort of knee-jerk reaction.
And I think that has happened in the
Yes.
UK. I mean, from the data that Fred showed, we do virtually no splenectomies in the UK.
Yeah, I think that's phenomenally successful.
I think that has been successful.
It's almost taken a generation to get that far, though.
But different in other countries, I do accept that.
No, it's because my surgeons at my own center know if they ever see a patient with ITP that's referred for splenectomy that has not seen us in our clinic, that they get that family to me and they don't take out that spleen. So I've also worked with my surgeons to say anybody, because we're a surgical referral center. So I've said, if there's a patient with ITP referred for splenectomy, please make sure that they get an appointment in our clinic for a second opinion and encourage the family for that second opinion. And I think that's the other side to work on it, is really educating the surgeons too. Or at least that's worked at my center.
We put that in the consensus. I think we said that no child should ever undergo splenectomy without having seen a physician with an interest in pediatric ITP, and we should probably do the same for adults. They should, in some district general, they should not undergo splenectomy unless they've seen one of us somewhere in the country to sort of ratify it.
Okay, in our last 10 minutes before we move on, let's cover 1 or 2 areas. And I just want to go back to the issue of diagnostics, because with the registries, we've got a lot of data. We're now collecting data, and John's stuff in the laboratory is extremely exciting. And there's this new sort of science called omics, genomics, metabolomics. Anything you can think of has an omics in it. There have been some nice presentations on metabolic changes that you may have a pattern that you can differentiate different things. And perhaps I'd ask John and then the others what they think about the likelihood of us picking up some test that's either genetic or relating to mass spectrometry that may allow us to have to substratify and maybe have a diagnostic study.
I mean, these studies are just starting to be done in ITP. I just reviewed a paper last month on metabolomics in ITP. So I think the thing is, again, the issue is when you do these studies on omics, it doesn't matter whether it's lipidomics, metabolomics, you get Excel files that have 90,000 rows of data. And so you need almost AI to evaluate them. And I think it's the way to go. They're expensive though, to do. But I think that and genomic sequencing is really the way still to go to try and understand biomarkers.
It's a waste of money. I would say, I think there's probably a waste of money because I don't think there will ever be a test for ITP because ITP is not a thing. We're trying to find a test for something that's so nebulous. I mean, Dr. Kuter, don't you agree? I mean, we're not dealing with one disease. It's not like a coronary artery blockage. This is something quite diffuse, which phenotypically looks the same, but it's multiple entities. You're never going to find a test for it. It's like a test for cancer. Wouldn't it be lovely to have a blood test that would detect? Well, because cancer is many, many things in many people. So it's going to be very tricky. And I think all these metabolomics and whatever.
Just remember, you don't believe that there is even such thing as primary.
I don't think primary ITP is a thing either. No, I don't think everything, they've all got a cause. We just haven't worked out the cause for most of them. And I think over time, all the primary ITPs, the 80% there, will all move over to secondary. They'll all be, oh, that's because of what this disease, this disease, this disease. So I think this the hunt for a test for ITP, a biomarker, I think it's it's not going to happen.
What about using registry data to identify cohorts and using your omics and genetics for risk stratification and disease response rather than etiology, maybe?
Yeah. Great information, planning, modeling, all these sort of things. That's absolutely fantastic. But it would be nice to be able to tell a patient what they actually have, because at the moment, hand on heart, you really don't know what they have.
You know, I doubt we're going to be at this situation where 25 years we're going to have a pregnancy-like test. You just dip it in the bottle and it's blue or green. It tells you if ITP. That's not going to happen. I think that we're going to look for genetic causes that make you susceptible to ITP or autoimmune diseases. But I doubt we're going to find a specific marker, John, that's going to identify clinically what's going to happen here.
No, but you might be able to identify response to therapies.
Yeah. And I think John showed quite clearly the multifactorial basis of it, that there are different things come to the fore in different people. And I think that's the issue. There's a question.
No, just to touch on this point.
Could you speak into the microphone, please?
Is that better?
Closer to your mouth.
And there?
Yeah, perfect.
In the mouth.
Yeah, if there's no possible test for ITP itself, is there a test for immune dysfunction? And is that something that would be possible?
There are tests, you know, Cindy takes care of the kids with CVID and other things where there's an immune disease that.
I mean, we do. So I think maybe in pediatrics, you know, again, approaches might be a little different, but we do screen. We work with our immunologists at our center, and there are some tests that we do to look for immune dysfunction, cytokines and things like that. And then we do look and we screen for underlying genetic kind of immune dysregulation, CVID, those sorts of things. I can tell you though, the times that I actually find something are quite low. When I find something, it's very, very helpful. The therapy pattern might change considerably in that setting, but I oftentimes don't find anything. You know, I send the panels, the cytokines are normal, the genetics are normal. There really is nothing that I can do with the labs that we have available to us that gives me an answer.
Okay, I think there's a question here.
Just a quick question. I heard just recently, about a couple of weeks ago, that the way that IVIG is allowed now has changed. So it's nationally, it's been said that it's only allowed to be used in emergencies, which was quite a new thing for me. Is that something that's negotiable? I'm just in a position where I've tried a lot of things and I'm finding now that avatrombopag isn't working at all. And as far as I know, I assume that IVIG is slightly cheaper than avatrombopag, because avatrombopag is very expensive. So I would have thought that potentially an infusion of IVIG now and then would be even better for the trust anyway, as it would be cheaper. I was quite surprised to hear that it was only used in emergencies.
I mean, for a number of years with IVIG being, strictly controlled with the NHS. I mean, the two ways of using IVIG, one is for rescue therapy in ITP. So this, in a way, is emergency therapy, or it can be used as replacement therapy. So some patients who have immunodeficiency syndrome have sort of regular immunoglobulin infusions. But for ITP, we don't use it as kind of a regular infusion. So it's always been in context of emergency treatment or rescue therapy. So I don't think that has changed.
Or for surgery for patients who aren't on chronic therapy because they can't tolerate, or so to get you over a certain episode or life event as well as acutely. Yeah, it has been managed by NHS England for a long time.
Yes, that
is very expensive.
it reflected availability. It reflects availability, and a lot was being used in neurological disease, and it wasn't available to be used freely. And this has been around for 5-6 years. That there's precise indications, but the indications you're talking about essentially can be defined as rescue therapy and would be permitted.
I mean, every trust has a meeting once a month where we spend the whole afternoon going through all the cases, all the patients who received IVIG. That's how it's controlled. That's how the supply is controlled.
Okay, I think there's someone there with the microphone. Oh, well, do you want to ask your question first and then?
All right. My question, do we know why we would still be getting mild bleeding symptoms while having a essentially normal platelet count on treatment?
You have ITP, I presume.
Yes.
Yeah, so some of us have published the fact that antibodies that are still binding to your platelets, albeit normal, are affecting platelet function. So we do studies called platelet aggregation studies. Most patients with ITP, albeit with a normal platelet count, will still have defective platelets. Usually mild bleeding, akin to having a baby aspirin once a day. So it's not something I'd worry a heck of a lot about.
Some of these platelet antibodies too cross-react with endothelium. And so that might be a reason too, and affect the endothelium.
It's also important to appreciate that with hemostasis, the ability for the blood to clot, it's not just platelets, there's a lot of proteins involved in coagulation. So if there was another problem, that could account for the bleeding. I just wanted to mention about your question about the IVIG, that you were suggesting, could I have it as a maintenance therapy? Now, as Professor Newland's already described, it's a very limited resource. So we don't, in the NHS, we don't really have enough of it to consider that as an option. Now, years ago, I've got some patients who, for various reasons, couldn't have steroids, and it was before the TPO receptor agonists, and I got 1 or 2 had a fungal infection who I did have on maintenance IVIG. So the thought that you're suggesting is it can work. Some patients, I had a couple of patients who every 6 weeks would have that, but I had to get special permission for that, and it was because of the limited resource for that.
Okay, thank you. Well, we've hit 5 o'clock. I think we've had actually a good discussion. There are various things that I still wanted to bring up, like vaccinations and thrombocytopenia, because that's raised a lot by our patient groups. David spoke about that at one of these meetings 2 or 3 years ago, and that's available on our website. But it's something we may revisit this year, because we have a lot of patients who say, I don't want any vaccination because it may cause thrombocytopenia. Yet the disease the vaccinations are trying to prevent you from have a far worse incidence of thrombocytopenia, and the clinical situation is much worse. And I think it's something we may revisit next year. And if I can summon up the enthusiasm and all the flack that I get, I may even answer the questions on Facebook. But anyway, I'd like to thank the speakers. We've had an excellent day. I think we've had a really good discussion now. I'd like to thank the companies who supported us, in particular Sobi, who are our platinum sponsors. We will be having the meeting next year, as I said, in Manchester. I'm moving around a little bit. And I'd like to thank Mervyn, who's really developed a really good day today, and his team, who've been stalwart in supporting everything. And I'd particularly like to thank all you patients and carers and partners for coming along today and taking part in what I think has been an excellent program with some really exciting discussion, both in the forum and actually outside upstairs, collaring people around. So thank you very much. I'd like to clap the speakers, but I'd also like to clap you as well for your contribution. Okay.